So, dear friends, we have seen in the first part about the unstable angina and the ST elevation myocardial infarction. In this section of the presentation, we are going to focus on STEMI, ST segment elevation myocardial infarction, its presentation, its diagnosis, risk stratification, and the algorithmic approach to the treatment plan of these patients. One important point that I need to emphasize is all patients of ST segment elevation myocardial infarction require an immediate reperfusion. This reperfusion can be in the form of either thrombolysis using a fibrinolytic agent or in the form of PCI, percutaneous coronary intervention. The first important methodology would be to see the patient gets PCI, but the limitations are the affordability of the patient and the transportability of the patient within the reasonable time to do a PCI. PCI requires, by definition, within 90 minutes we need to transport the patient. How many of our patients really we can transport them in that short time after they really get the pain? So the pain to door and pain to balloon time is very difficult to control in an environment like ours where we have several bottlenecks and patient understanding about the disease is very, very poor. Even the physicians in the first instance may not suspect acute coronary syndrome and some valuable time may be lost. So in such a scenario, primary PCI may not be really feasible for all the deserving patients. In such cases, of course, we have got an option of reperfusion or recanalizing the vessel by doing what is called fibrinolysis. We have got the third generation fibrinolytic agents today, which can be given as single shot injections. And then, of course, the patency rates are very good with these injections. TNK or tenelactopase is the brand or the drug that we are going to use, which we will focus in our discussion on STEMI. So after going through these reperfusion strategies, I will explain you the drug treatment and also the post-myocardial infarction treatment and about the complications, the most dreaded of which is cardiogenic shock, with the mortality as high as 60 to 80%. So these will form the discussion of this presentation of mine.